Hi, everyone. My name is Zach Hodges. I'm a pediatric hospitalist here at MCG. Thanks, Dan and Nicole, for another opportunity to work through this week's video podcast. Week 16, we'll be discussing a case of septic arthritis in an 11-year-old. So let's get started. So our patient is an 11-year-old who's brought to the ED for right hip pain for several weeks duration. Mom states that the pain really began after a walk, but no real trauma. Now it's gotten worse and is limiting the mobility. The pain's mostly in the right hip region. There's no pain at rest, but extending the hip for any reason causes severe pain. Initially, she walked with a limp, but now does not want to bear weight. Seen in urgent care and was treated with all these medications that we will be sure to explain in detail. Review of systems, really no fever, not really otherwise contributory. So what comes out when I first look at this history, thinking about the hip pain of several weeks duration, we talked about this a little bit last week, but what causes acute pain versus subacute versus chronic. This several weeks in duration feels more subacute, so it doesn't really seem like like an acute infectious septic arthritis. And then this kind of several weeks duration will definitely play into our case later. Feels different than our JIA from last week, which remember requires up to 6 weeks of pain before you can make that diagnosis. So moving on, it's mentioned here that she has tenderness in the right hip area. I thought it'd be important to point out that true hip pain is typically perceived as groin pain. And even in children, you can have referred pain from the hip to the thigh or even the knee. So kind of taking in consideration all the other joints, above and below the joint of interest is important. When pain kind of localizes to the lateral upper thigh, kind of overlying the greater trochanter, it really makes true hip disease less likely. So what anatomic structures could be potentially affected? Really anything around in the hip and the pelvis, and that's included here. So based on that list, what is our differential here? So when I think about infectious, these are typically acute onset. Patients have fever, they have elevated white counts, they have a CRP, a SED rate. Think about septic arthritis, Lyme disease, and osteomyelitis. With inflammatory, these can be acute, but most of the time it seems like subacute, and some may even be chronic. These patients may have systemic findings like other joints, may have rash and fever. Also with like inflammatory, transient synovitis is a more common cause in younger children of hip pain, and it's thought to be secondary to a viral infection. Trauma is usually something you can gather by history. With an 11-year-old, they should be able to give you a good history of that. Definitely want to examine and interview our patients alone to get a clear history if they're appropriate age. With autoimmune, when you think about back to last week's case with JIA, remember 6 weeks of symptoms. Usually they'll have systemic findings as well. With neoplastic, leukemia and osteosarcoma can present with hip pain. This pain, traditionally, classically, is worse at night and is not related to activity. These patients will also have abnormalities in labs, including like LDH to be elevated, uric acid to be elevated. There will be problems with the CBC. And kind of I added this one here. Some must not miss diagnoses be like a slipped capital femoral epiphysis or SCFE, and then Legg-Calvé-Perthes disease or LCP. And also considerations in pediatric patients. Sometimes right lower quadrant pain can be inferred to the hip area, so appendicitis, urinary tract infection, even urolithiasis should be considered. Here's a nice little flow chart kind of working through hip pain depending on different exam findings. It might be helpful to review that with your students. So moving on more to the past medical history, there's none. Surgical history, none. No allergies. Medications. So she was seen in the urgent care 2 weeks ago, and she's taking acetaminophen with codeine or Tylenol No.3s, Q4 hours as needed, tramadol, cyclobenzaprine, and prednisone. So I feel like we should hover in here. So first, codeine is now contraindicated for children less than 12 years of age, and this is something that our students may need to review. So it turns out that codeine's like a prodrug, so it's actually metabolized into morphine, and there's a subset of the population that can be hypermetabolizers, and essentially when they take codeine, they're essentially getting a bolus of morphine, and this has been described in case reports of causing apnea and death, especially in younger children. So usually it's not used in kids, especially those less than 12 years of age. Tramadol is also carries the same contraindication. It's a not typical narcotic, and it has various side effects and various actions. And in kids, we really try to stay away from it. Next is cyclobenzaprine. This is a central acting muscle relaxant, not used in kids. And kind of thinking about this patient's history, muscle spasms really don't seem to be the etiology, and this is not a great idea to add this medicine at this time. So exploring all these side effects could be helpful with your students. And last, steroids here. So giving steroids without a diagnosis would be concerning for this patient. Examples would be like if this was a malignancy, using steroids could delay the diagnosis. It could even upstage their disease because quite commonly corticosteroids are used in the first line treatment to achieve remission. Also, if there's like an infection of the hip, that could definitely dampen the immune response and it could lead to worse outcomes there. So I'd be really concerned about seeing the prednisone here. So social history, lives with mom, 5th grade student, does well academically, no smoking or drinking in the home, no guns, up to date on vaccines. She's also 11 and kind of sensitively screening for sexual activity and sexual abuse is important. 11's about the age that we start thinking about that, kind of depending on the case, and keeping in mind that gonococcal and chlamydia can lead to arthritis. The family history is mostly non-contributory. Review of systems, again, highlighting here no fevers, which really makes you think this not infectious at first here. No bruising, no bleeding, being reassuring that maybe there's no kind of leukemia, but still want to look closely. So this is kind of going back over things we said so far with codeine and tramadol and cyclobenzaprine. Feel free to review. Moving on to our patient's physical exam. So somewhat tachycardic at 104, but the rest of the vital signs are within normal limits. Her BMI is greater than 99th percentile for age and sex, and that would increase her risk for a slip capital femoral epiphysis or SCFE, and that's something we can discuss a little bit later. Kind of moving on to the rest of the physical exam, we have no lymphadenopathy. The abdominal exam, cardiovascular exam are normal. There's no CVA tenderness, making me think like a UTI or a kidney stone might be less likely. For musculoskeletal exam, she has pain in the proximal femur and is tender to palpation laterally near the greater trochanter with diffuse tenderness over the lateral thigh and buttock. So they didn't really describe groin pain here, and they even describe more like tenderness over the lateral thigh and over the buttock. So it makes me think less likely about hip pathology, and I'd really want to consider, lower back, SI joint, thigh, other places other than the hip. Refuses to move the right hip, will not bear weight on the right leg. The left leg and upper extremity is normal. So also in pediatrics, remember we want to examine the affected area last, because as soon as you move a joint that hurts, our children will probably not give you a good exam the rest of the way. Neurologic exam, good strength, good sensory. And I also included here, including a careful skin exam is important. If there is evidence of cellulitis or breaks in the skin, that could be a source for bacteremia and could lead to a septic arthritis. So describing the pertinent findings, no deformity, no redness, there is some tenderness to palpation. Keep in mind that this is an incomplete exam. We're not able to range that right hip like we wanted to. More information about how they'll have to use these skills on their USMLE clinical skills exam. Okay, so now that we have the whole HMP, what are most likely and what are the must not miss diagnoses? So first is the slip capital femoral epiphysis. Remember, that's when there's displacement of the most superior part of the femur when it kind of is displaced as compared to the femoral neck. That's an emergency, needs emergency pinning and fixation. Next is avascular necrosis of the femoral head. That is also something that needs orthopedic attention you don't want to miss. And then septic arthritis, of course, bacterial infection of the joint that needs aspiration and antibiotics. And that's been detailed here. So how do we get started in working up this patient? So getting blood work is a great start after we've taken our history and our exam. We want to evaluate for signs of inflammation, infection, and trauma. So a CBC with differential, BMP with a calcium, Serratia, CRP, and blood culture. So CBC will give us evidence of inflammation with a leukocytosis and a left shift. BMP and calcium will be necessary because some of our antibiotics that we may choose to use may be nephrotoxic, so having baseline values would be helpful. A Serratia can tell us about inflammation, and so can a CRP. And a blood culture would be very, very helpful if it was positive, but keeping in mind, in cases of septic arthritis and even osteomyelitis, it's not likely that they're going to turn positive every time. So let's look at our patient's lab results. I see a mild anemia of 11.4, it's kind of borderline, but a low MCV. Thrombocytosis with a platelet count of 457. White blood cell count of 14,000, 52% neutrophils, and 2% bands. There are 38% lymphocytes. So not the most concerning differential, but there is somewhat of a leukocytosis. Sometimes an elevated platelet count of 457,000 can be a sign, a soft marker of inflammation. And also, again, you see that mild anemia that may be suggestive of an ongoing inflammatory process. Moving on to the electrolytes, the CMP is mostly within normal limits. The SED rate is elevated at 67. The CRP is elevated at 2, both suggesting an inflammatory condition going on, but really non-specific. D-dimer was normal. So next we have a pelvic x-ray. Not something that I see very often, but it can be helpful when you're evaluating for cases of hip pain. This is a normal example, and then looking at our patients. So first, what comes to mind for me is ruling out the cases that we don't want to miss. So first would be a skiffy. And the right hip is the one in question. And what we want to make sure is that the femoral neck is kind of congruent with the epiphysis here. And it definitely is. So the buzzword that our students will learn is when there's a skiffy, the x-ray will look like an ice cream scoop falling off of a cone. So you'll see the neck displaced compared to where the epiphysis is. Next, looking for evidence of late findings of osteomyelitis and avascular necrosis, which would obviously be several weeks down the road. You would see like asymmetry. You would see kind of darkening in the femoral head. Really, the hips look normal. Kind of as we think about where the patient's pain is, kind of in the thigh and over the buttock, there is some like subtle asymmetry, and I didn't see this at first, where the right SI joint is definitely wider compared to the left, and there's even some erosions there. That would be very concerning, and that's something that was mentioned in the case later. So their official interpretation in this case was normal study in absence of relevant clinical history, so giving a suggestion that maybe something was missed. So here they mention again about the asymmetric widening of the right SI joint and those erosions would be really concerning for an ongoing infection. So we mentioned the pertinent lab findings, more information about the SED rate and the CRP. And the next steps, we don't want to miss the skiffy, septic arthritis, and avascular necrosis. So an X-ray is definitely the first step in evaluating for these pathologies, but it's not very definitive. Ultrasound can be helpful for evaluating some joints, but the hip really doesn't do a great job because of it's a really mostly enclosed joint, and it's hard to get a great image of the hip. A CT scan is not used to evaluate this, and an MRI, most often with the contrast looking for infections, is most likely used. So one of the take-home points is for septic arthritis is that this is a diagnosis made by actually getting fluid. So an MRI can show inflammation, but you really don't know it's infected until you actually get the fluid and put it under a microscope and see the gram stain and grow the culture. And we'll talk more about how maybe that wasn't done initially in this case. So our patient is admitted and they get an MRI. And here, this is a T2 MRI. So everything white has lots of water. And you see there's a little bit of asymmetry kind of in the SI joint. See there's a bit more signal here on the right as compared to the left. And that's concerning for some type of inflammatory process. and they comment on it here. Small amount of fluid in the right SI joint concerning for septic arthritis or osteomyelitis. So what's done next? When you have a concern for septic arthritis, we mentioned earlier, you really want to get fluid from the joint and culture it. And this helps you guide your therapy as well. For this case, they go on to describe how the fluid was not obtained and they started treatment without it. So that brings up the thought of a medical error has been made. So working with our students on what the process looks like to appropriately communicate that an error has been made with a family is important. And we can use these resources to help them walk through that conversation. All right, moving on to part 2. So blood cultures were drawn with aerobic and anaerobic cultures. She started on IV clindamycin. One comment here, clindamycin, remember, you can review that with your students, that it's a ribosome inhibitor, and they'll probably be familiar with the 50S subunit. It's relatively narrow and really only has about 75% coverage of MRSA here in our pediatric hospital, the last that I remember looking. It's not the best broad therapy that we think about for most septic arthritis. So I just thought I would mention that here. Another thing with this case, she had several weeks of leg pain, and that makes me lean towards this might not be a typical organism like staph or strep causing her osteomyelitis. That might be a clue that she may have an atypical organism. So 1 week later on IV antibiotics, blood cultures are negative. The patient was sent home on IV clindamycin. Discharge CRP was 0.5, down from above 2. So she returns to the clinic after 6 weeks of antibiotics. Mom says that she initially improved, but now she's starting to limp. The repeat CRP is up above 3, and it's elevated. So she got 2 more weeks of clindamycin, but 7 days into the treatment, she has increased limping and pain in her knee, and she's brought back to the ED. So this pain in the knee is interesting. Sometimes when they have one joint that's hurting, they'll kind of overcompensate and rely on other joints more. We may be seeing that here, but we definitely want to be sure there's not another infection going on. Seen in the ED, she's febrile again, and she's admitted to the Children's Hospital. We talked about the rationale for blood cultures. We talked about clindamycin. And we talked about how this may be an atypical organism and how clindamycin may not be the best empiric choice. So what should we have done earlier on to make sure this patient gets the best management possible? Getting joint fluid like an arthrocentesis is what is needed to happen. So our patient is admitted and gets a second MRI, and we're looking at an axial view here of the pelvis, and you can see that there is definitely increased signal in that over that right SI joint. You can even see some widening there as compared to the left side. That was read as periosseous edema, osteomyelitis, and pyomyositis with abscess formation. So very concerning for an infection. So here you can review with your students, the different views that we see on these 3D imaging studies, axial versus coronal versus sagittal. I feel like for me, sometimes as a generalist, a pediatrician, sometimes I can better appreciate anatomy on the coronal and sagittal. It seems like the traditional way that radiologists read images is with the axial. So our patient was taken to the operating room for a washout of the involved joint. So the SI joint was open and irrigated. Remember that for most of these, they'll use like an image guidance, whether it be ultrasound or maybe a CT. Gram stain of the smear did not show any organisms, but there was neutrophils, so that's giving us suggestions that there is an inflammatory process, but since there was no organisms, maybe it was more of one of the bacterium that are a bit more indolent. So the cultures are pending, and then she has started on IV vancomycin and piperacillin tazobactam or Zosyn. This might be a good opportunity to talk about how do we choose empiric antibiotics. That really entails the site of infection, the common pathogens that you're considering, and then data on prevalence of resistance. So we mentioned earlier that staph and strep are the most common causes of of subject arthritis, and probably MRSA is probably the most common. Clindamycin doesn't cover all of the resistant MRSA in our community, so vancomycin is a good example here. Another consideration is side effects of antibiotics. So vancomycin is a known nephrotoxic agent. There's some evidence in pediatrics that the combination of vancomycin and piptazo may even be synergistically rhinotoxic, even though that's not quite all well described. So our patient culture comes back, and you have these gram-negative rods on your culture, and that's quite odd. So this was diagnosed to be Serratia. So the antibiotics were changed to cefepime and gentamicin. So what is Serratia? We've already mentioned it's a gram-negative rod in the Enterobacteriaceae family. Typically, you see it with hospital-acquired infections. It's also traditionally resistant to multiple antibiotics. Recurrent infections may suggest an immunocompromised patient. Really interesting in this case that there wasn't a great history for hospitalization or any kind of contact with high resistant drugs, high resistant organisms. Didn't quite fit here, and I think that explains kind of the indolent hip pain and not recovering by traditional therapy. Says you want to consider ruling out immunocompromised conditions if patients have maybe more than one infection, but maybe not one would be enough to do a full workup. So because of the high resistance, we use really broad agents like cefepime and gentamicin. So moving on to part 3, we have a paper here that we'll review in EBM format. It's a review article on Toradol and some of the safety considerations that we mentioned earlier in our discussion. And then finishing up this case, 2 weeks after finishing antibiotics, patient and mom come to the ID clinic for follow-up. They're happy with how she is doing. However, mom wants to draw one more set of blood cultures just to be sure. And that brings up a great conversation about the 4 core ethical principles that we must follow in taking care of patients. So why is this come important? Because we know that drawing extra blood cultures is an invitation to add complexity to a patient's care. If a patient is not clinically ill, the risk of getting a contaminant or a false positive is much higher than getting a real pathogen, and that could result in patients getting more IV antibiotics and inviting more risk for hospital-acquired complications. So first we have to consider autonomy. We want to respect the patients as individuals. We want to honor their preferences. Beneficence, we want to act in our patient's best interest. We feel that it'd be best for the child not to have an extra set of blood cultures, and we definitely don't want to harm the patient. So non-maleficence. And moving on towards justice with distributive justice and formal justice, thinking about allocation of resources and treating people equally. So you can use that to guide your conversation with your students. So how do we have this conversation with the family? So some data here: 53% of physicians would say they'd order unnecessary tests if a patient was insistent. There are even some malpractice concerns and even some considerations that maybe if you didn't know a family as well, it was only your first or second visit with them, you may have a leaning towards doing more studies than may be necessary. And there's also considerations for cost of healthcare that we can explore with our students here. So anyway, that's it. I really enjoyed putting together this video podcast. Please let me know what feedback you may have, and please enjoy your week. Talk to you next time.